Hi guys, this is Amanda Curtis, nurse practitioner. I wanted to jump on and do some education. I know a lot of people were asking specifically wanted to hear about women's hormones and perimenopause and menopause education. So I'll try to go through some of it so we at least I'll start like a series where each time I'll talk about a little more on the topic because it's a lot to cover. But I'll kind of go through what I talk to my patients in the treatment room about and how we navigate this space. So first I'll start with the definition of what is menopause and perimenopause. So menopause is technically defined as your last menstrual cycle, but the diagnosis isn't given until retroactively a year later that you haven't had a menstrual cycle. So, but 10 years prior to that last menstrual cycle is when we consider perimenopause. So that's when a woman can start to see changes in mood, changes in sleep. You can start to see symptoms of like hot flashes, night sweats, irritability, mood swings, also bone loss, collagen loss, you name it, and also mental, so brain fog. It affects our cognitive abilities. Up to 10 years prior is considered perimenopause. So those are the two definitions that we'll start with. So who does this affect? Well, this affects women. The average age of menopause in the United States is 52, 53. Some women can go in before, so as early as 45 is not considered abnormal. The best person that a woman can talk to figure out when she'll go through menopause is actually her mother. So the age that your mom went through menopause is most likely as close as you'll get to understanding when you're going to go through menopause. So these are things to consider when we're talking about, are you in the zone, essentially? So a woman who is technically 35 could be considered perimenopausal because 45 is not considered an abnormal, but anything before 45 is considered premature menopause. So now that we have these definitions in mind, we can start to look at women that are these ages and what changes are going on with them biologically. So most women, their first symptoms are going to be things like increases in anxiety. And that is why a large majority of women start to be prescribed SNRIs and SSRIs at this age, because they're sort of misdiagnosed with the drop in progesterone that they're seeing. They're not able to handle their stress as well. Something's a little bit off. They're very irritable. They're snappy. They, are fighting with their spouse or their children. And it's a very stressful, tumultuous time for women in general because we usually have young children in the house, or, there's just a lot of change. And so we're not quite sure what it is and we can't put our finger on it. But looking back, I can tell that there was a definite change in myself to when I wasn't handling my anxiety the same as I normally would. So based on these definitions, when I have a woman come to me, I'm thinking if she's between the ages older than 35 to 52, we're considering that she's in perimenopause. I can draw labs, and yes, labs matter, but labs are just, I listen to the patient, I understand where she is in her life, and I'll throw up, there's a graph that kind of shows and looks at a woman's life cycle. So from puberty through reproductive years and into perimenopause and menopause. And so peri is considered the zone of chaos when our hormones are all crazy and out of whack. Think of it like puberty in reverse. Okay, so just as crazy and wild and tumultuous as your puberty years were, that is kind of what's occurring, but in reverse for perimenopause. So some months, the anterior pituitary, so it secretes LH and FSH, which talk to the ovaries. So there's a feedback loop that says the LH and the FSH are detected in the anterior pituitary, and they're scanning the blood looking for these levels of hormones. And if there aren't enough hormones, the LH and FSH rise, and they tell the ovaries, hey ovaries, can you give me some more estrogen? I'm a little low this month. And the estrogen, that's estradiol that is produced in the ovaries, they're running on empty. They're kind of at the end of their life cycle, so they're about to go in retirement, and so they are maybe 1 month unable to provide enough estrogen. But then the signal keeps getting stronger and stronger, and so once the ovaries are like, ugh, there's like this huge surge of estradiol, and it finally kicks out some estrogen. And that's why 1 month you may have heavy periods because the lining of the uterus grows and then it sheds, but you could have prolonged periods that just kind of linger and last forever. But it's all dependent. It's because in this time frame, our cycle is just up and down and all around, and the progesterone's up and the estrogen's down, and so that's why it's a very tumultuous time. Hormones are crazy, and so my goal for my patients is to just provide enough estrogen for the body to realize that it is okay. It's at a safe level. It's because your ovaries are still producing something, but they're on the way out. And so my job as a clinician in perimenopause is to give your body enough to feel safe so that your FSH and LH are not screaming. And then that way it's able to calm down and things are able to get back to kind of some symbol of normalcy. The other hormone that I like to talk about, and it's very, very important and misunderstood and overlooked by a lot of clinicians, is progesterone. And so progesterone is really that anti-anxiety hormone that signals to our body the calmness. It comes on board in the later stages of our luteal phase. So during our cycle, we have the follicular phase, then we have ovulation, and then we have the luteal phase, and then we have the monthly withdrawal or the shedding, so our period. And progesterone is the important hormone that comes on board the second half of the cycle. It helps to stabilize the endometrium, but it also is wonderfully helpful for sleep. And so in perimenopause, a lot of women, that is the first hormone to decline. And that's when we start to see increases in stress, anxiety, lack of sleep or sleep disturbances, insomnia, these type of things. And so usually in perimenopause, I'm focusing on progesterone and I'm focusing on estrogen replacement, but at a lower level. Again, and it's based on a woman, it's based on her symptoms. Someone's dose is not someone else's dose. So don't compare, because sometimes it's absorption, sometimes it's the way that you're utilizing it, sometimes it's your estrogen receptors. There's a lot of confounding variables that we need to consider. So most importantly is finding a clinician who's willing to, number one, listen to you, listen to your symptoms, take you seriously and not blow you off. That's really important. And then just to work with you to be able to manage those symptoms appropriately. So this was a quick lesson just to kind of recap on perimenopause. I'll do other lectures on menopause and other hormones like testosterone. But for this, I also just want to reiterate that hormones are a personal choice, and they are not the same for everyone. So a woman who has a very strong family history of breast cancer, uterine cancer, ovarian cancer, anything like this, we want to just be aware of histories and that it may not be for everyone. Even someone with a personal history of breast cancer, we have to be very understanding, because it is a risk versus benefits discussion. The most important thing for each individual patient is that they are educated on the topic. So I present the facts to you, you understand your risks and benefits, and decide whether you would like to initiate hormone therapy or not. It's not required by any means, but understand that there are so many benefits from it that you will be missing out on. And I think that for the longest time we've been misled to think that it caused worse outcomes, and that is not the truth. So we can, in another video, I'll recap and rehash all of the Women's Health Initiative things, but I'm sure you can find that everywhere on the internet. But where they used to think that a body identical hormone that we've had our whole entire lives as women somehow causes breast cancer, and that is not true. So we'll discuss that on another time, but thank you for sticking with me this far, and I hope you gained some education out of today's talk. If you want to know anything further, let me know in the comments. I'm happy to address different topics, or if you had a specific topic in mind that I can dive deeper into, please let me know, and I look forward to our next video. All right, take care.